Well, good afternoon, and welcome to everyone in joining us here in our Washington, D.C. office at Mathematica Policy Research. Also, welcome to everyone listening in by webinar. I'm Gene Rich, and I direct the Center on Healthcare Effectiveness at Mathematica. It's my pleasure to welcome you to our policy forum and webinar on the lessons learned from our midstream assessment of the Recovery Act investment in comparative effectiveness research. A few words about the Center on Healthcare Effectiveness before we start. We conduct and disseminate research and policy analyses that support better decisions at the point of care. We focus on the delivery system and policy environment which helps clinicians and patients make more informed decisions and better use of information on outcomes and effectiveness. For more information about the work our researchers are doing or upcoming events, I encourage you to visit our website. Now a little bit of background for our forum. In February of 2009, the American Recovery and Reinvestment Act appropriated $1.1 billion for comparative effectiveness research, directing $1 million to the NIH, $2 million to ARRA, and $400 million to the Office of the Secretary of HHS. From this, more than 400 projects sought to address CER priorities, from actual research to developing databases for comparative effectiveness, training new researchers, conducting dissemination and translation of findings. Today, my colleague Dominic Esposito, the Senior Researcher and Deputy Center Director at Mathematica, will describe the findings from the midstream assessment of the ARRA CER portfolio of projects. This evaluation identifies early lessons for policymakers and can help inform future efforts to facilitate the development and use of comparative effectiveness research. I'll then share a few lessons learned for evaluating the longer-term impact of CER in patient-centered outcomes research investments. And we're privileged to have an esteemed panel of evaluator and CER thought leaders join us to react to these evaluation findings and their implications. First, Shelley Greenfield from the University of California, Irvine, will provide reactions in the context of past and current challenges faced by the community of scholars in meeting priorities for CER. Shelley's many roles in the Recovery Act CER investments included co-chairing the IOM CER Priorities Committee. Next is Sandy Schwartz from the University of Pennsylvania. Sandy is a clinician health services researcher who studies medical decision-making and the adoption and diffusion of medical innovations. He'll share his perspectives, particularly on lessons learned for evaluating the future impact of CER and PCOR investments. And after that, Brian Luce, Chief Science Officer at the Patient-Centered Outcomes Research Institute, will offer observations on the implications of the findings for current policy and funding agencies like PCORI. Before we get into the real meat for the afternoon, a couple of housekeeping points. Our session today includes both an in-person and an online audience by webinar. To help ensure the highest possible sound quality, please put your devices in DC into forum mode, which would be silent. Also note we're video recording today's sessions and may capture images of some of you in the audience. So, be alert to that possibility. You unfortunate events, in recent videos that you may think of. Not here, of course, not here. This video will be posted on our website later in the week. At the conclusion of the discussant remarks, we'll entertain questions from both our in-house and webinar audiences. For those of you participating by webinar, please submit your questions electronically through the Q&A panel on your screen. We will alternate questions between our in-house and webinar audiences. And now I'm pleased to turn the program over to Dominic Esposito.
My microphone was on. The SEC and IOM released their seminal reports on CER less than 6 months later, and only about a year after ARRA was passed, projects were awarded to more than 420 different teams. So essentially what we're trying to say here is that awards were made very quickly after the passage of the Recovery Act. The evaluation of the portfolio that Gene and I led began in August 2010 and ran concurrently to all the other Recovery Act projects in the portfolio. So this means that measuring success would be gauged by short-term process metrics rather than longer-term metrics. This also meant that we would not know much about research findings for most of the projects in the portfolio since the evaluation itself was ending while most of the projects were wrapping up. Around the same time, this little piece of legislation called the Affordable Care Act, perhaps some of you have heard of it, was passed in March 2010. For those of us who don't know, the ACA gave us the new term, patient-centered outcomes research, defined as something distinct from comparative effectiveness research. So while the ARRA CER-funded investigators were conducting their work, there was this fundamental shift and change in thinking in the field as well. So there's a number, just some of the challenges we have to face as a team thinking about this evaluation. So we wanted to summarize for you our evaluation objectives and approach. So first of all, our job here was to describe what was learned from the ARRA CER investments relative to the Federal Coordinating Council for CER and HHS goals. And second, to provide guidance for future CER investments and evaluations. What we do and what you're going to see today is that we focus on findings across the entire portfolio. This means that we didn't focus on findings from specific projects. So we don't make a judgment on quote-unquote winners and losers of projects or projects that were shining lights of success. What we do here is focus on findings across the entire portfolio to really get at our main purposes. And the last point we wanted to make here is that for the midstream evaluation, what we did was we used data collected while the projects were ongoing. So we did a review of all the redacted project proposals. We did an investigator survey at the midstream point of the projects. We also had many, many discussions with select project officers, investigators, and other scholars throughout the course of the project to really get at our main purposes. We wanted here to highlight the questions that we were addressing in evaluation at the highest level. So we were looking to examine what types of investments were made with ARRA CER funds, how the ARRA CER portfolio of investments began to address strategic priorities for CER, what midstream findings we can identify that can inform HHS, and what were the implications for future federal investments in CER. I'm going to address these first four questions today, and Jean is going to address the last one, which is what are the lessons learned for evaluating the long-term impact of ARRA or other CER investments in the future. So first we're going to tackle the first two questions here. Nearly half of all the projects had a primary area of focus of research on comparative effectiveness, including both evidence generation and evidence synthesis. Nearly a quarter of the projects had a primary focus on the creation or enhancement of data infrastructure for comparative effectiveness research. These investments were diverse. There were projects that linked the data across health centers, developed natural language processing algorithms for text-based data and electronic health records, and enhanced federal data like Medicare and Medicaid data. There were also substantial investments in CER methods development, where projects addressed a number of priorities for research using observational and clinical trial data. CER training programs, where most programs built on or augmented existing training programs. And CER dissemination and translation, which consisted of projects that tested novel or adapted dissemination approaches, developed infrastructure to support dissemination and translation efforts, and established collaborations and partnerships to carry out dissemination efforts. So as you can see from our wheel diagram, what we've done is categorize projects based on the core areas of investment identified by the Federal Coordinating Council for CER. And this just gives us a different picture here of the same one we showed before. Now, many ARRA CER projects had multiple areas of focus. What we wanted to convey with this graphic was that many projects had those multiple areas of focus. And you can see here that about 3/4 of the projects had a considerable research on comparative effectiveness focus. This included projects where research was considered both either the primary focus, which we denote here in red, or the secondary focus, which we denote here in purple. Now, in this slice, we examine the purple. We examine the project that had a secondary focus in research in a little more detail. And we can see that we have an emphasis here on research spread throughout the portfolio in all different types of projects. For example, the research-focused data infrastructure projects had a secondary research focus, methods and training projects, and dissemination and translation projects. So for example here, the data infrastructure projects were building or enhancing data that we need to conduct CER, but they're also testing that infrastructure through generation of new evidence. A number of methods projects also had a research component, and many dissemination and translation projects also had a research component. So for example, one project examined the dissemination of information to vulnerable patients about biological therapies to treat rheumatoid arthritis. As a part of their study, investigators conducted a randomized controlled trial where they varied the amount and kind of communication between patients and physicians based on materials prepared for the study. Researchers were interested in particular in measuring knowledge of medication choices, satisfaction with patient-physician interactions, treatment uptake, and adherence to treatment. This right-hand pie chart here gives us a sense for what types of projects were kind of in our other category. Again, they were spread throughout the portfolio, and it gives us a sense for how diverse the portfolio was in general. In thinking about priority themes addressed by the projects, what we can see is that nearly 80% of all the projects address either a priority population, condition category, or intervention category, again defined in the Federal Coordinating Council for CR's seminal report on CR priorities for the nation, suggesting that investigators are really addressing topics that are likely to provide useful findings in key areas of research. Not surprisingly, more than 90% of research projects addressed one of these priority areas. But perhaps slightly more surprising was that a large proportion of data infrastructure and dissemination and translation projects also addressed many of these priorities. It's also important to note, and I'm going to expand on this in the next slide, is that 40% of the projects addressed at least one Institute of Medicine IOM priority topics for CER. When we examine the portfolio from that lens, the IOM priority topics for CER that were also addressed, the portfolio again looks very diverse. So the most common areas of research, for example, were research on healthcare delivery systems, research on racial and ethnic disparities, research on cardiovascular and peripheral vascular disease, and oncology and hematology. So that was our last slide on how the ARRA CER funds were allocated and the extent to which funds began to address priorities for CER. As a part of the evaluation, we dug a lot deeper into many of these different areas, and we're happy to take questions on it in the discussion period. But what we're going to do now is turn to the third and fourth research questions. Specifically, sorry, let me click that for a second. What were the midstream findings we identified that can inform HHS? And what are the implications for future federal investments in CER? So to provide a little context for this, in conducting our evaluation, what we wanted to do was consider the ultimate users of the findings, which were policymakers at HHS, who have continued responsibilities after the Recovery Act projects were completed to further develop CER programs and research agendas. In particular, what our findings and implications account for include the fact that 20% of the patient-centered outcomes research trust fund monies are allocated to HHS. 80% of those, about 80% of that 20% are allocated to ARRA to train researchers and disseminate findings, and 20% of that 20% to the Office of the Secretary of HHS to build data capacity. In addition, we all know that NIH and ARRA have continued authority to conduct CERs funded through appropriations, and that HHS has responsibility for legal, regulatory, and policy guidance relative to clinical research. So as you develop findings and implications, this is really what we're thinking about in the background. What we've done is identify findings and implications by the basic core areas of investment for comparative effectiveness research. So what I'm going to do today is go through findings and implications on each of these core areas. We're going to start with research on comparative effectiveness research. And we're going to start with the key findings. So key findings include the six we see here. Wanted to highlight that team members from non-research organizations that are particularly important contributors is one thing that we found in our research. Really what we heard is that understanding of our connection to the data sets was key in this case, and also was important that we included team members in clinical settings and patient populations. And examples of different team members and different non-research team groups were health plans, private medical practices, and community hospitals. Stakeholder engagement is also important, but challenging and resource intensive. Multi-organizational collaborations were a prominent feature of research projects. In particular, we found that 70% of projects that generated new evidence, so research projects, had investigators from more than 2 institutions. We also found that achieving a shared understanding of project goals and expectations across the project team is helpful to achieve success. And a deep understanding of differences among organizations and settings facilitated collaboration. And last, what we found is that various strategies can facilitate multi-institutional CER projects. So turning to implications on the research side. What we found is that HHS might consider providing guidance to address varying local interpretation of privacy regulations and human subject protections. In particular here, challenges that are varying institutional interpretations of privacy regulations and human subject protections and researchers' conflict of interest. Solutions here might be aided by better understanding of different concerns observed across types of projects and composition of teams, including the non-research organizations. We also identified that study differences in private payer coverage for multi-site trials is a place for CMS to continue, for HHS to continue thinking about going forward. HHS might consider reducing the time between proposal submission and award notification to help sustain momentum for projects, particularly those involved in non-research institutions. Might identify best practices for managing multi-organizational collaborations, creating support tools to facilitate cross-site data collection and data sharing, and identifying best practices that facilitate our stakeholder engagement in CER design, and supporting efforts to engage stakeholders in CER design overall. Turning now to research training and career development. What we found here is that multidisciplinary support and mentorship are important to the development of new CER researchers. That CER training programs must employ strategies to accommodate diverse educational backgrounds and future research roles. That CER is not a specific scholarly discipline, but is rather a broad multidisciplinary field of research. That a variety of competencies are currently required by CER trainees. And those include framing CER research questions relative to decision makers, understanding CER relevant study designs and statistical methodologies, multidisciplinary and multi-institutional collaboration, and working with non-researchers as collaborators. In addition, we found that CER continues to evolve, and advances might require additional competencies going forward, particularly in thinking about CER methods, data sources, and stakeholder engagement techniques. And lastly, we found that maintaining CER-specific curriculum might require continuing support going forward. In terms of implications, what we think this all means is that HHS should consider promoting strategies that prepare researchers with diverse educational backgrounds for the broad range of careers in CER. That programs should consider updating training curriculum and incorporate new CER developments, particularly CER developments in CER methods and data sources, and that the training and engagement of clinicians and patients in CER design. We also think one implication is, it's important to support engaging people with diverse disciplines and clinical perspectives in CER training. And lastly, that supporting mentoring and training involvement in CER projects is important going forward. Turning now to method development projects. What we identified here was that access to data with sufficient clinical detail was an important constraint for some methods projects. And this is really reflects an emphasis on using existing data to answer real-world questions to inform clinical decision-making. Second, we found the opportunities to improve availability and usability of new CER methods should be continued to be developed. This really emphasizes the importance of investigators knowing what CER methods already exist and being able to apply those methods in their own work. Multiple investigators who we talked to noted there are still ongoing challenges with doing that, and that avenues to sharing new methods with one another would be welcome. We also identified that CER methods research teams require a broad range of skills and expertise, that the use of different terminology across disciplines is a barrier for methods development that should be addressed. That projects examine a diverse array of topics, but many priorities remain for continued work, and that information needs of decision makers can inform future CER methods priorities. So what are the implications for HHS? We think it's important for HHS to consider supporting efforts such as learning networks to increase dissemination and usability of CER methods. Really having a better understanding of CER methodologies that already exist and identifying ways to support learning networks can hopefully enable greater exchange of ideas and about gaps in methods research and potentially improve the usability and availability of work through, for example, the sponsorship of a central repository for information. We also think HHS could consider supporting collaboration among CER methods and data infrastructure investigators. The bottom line here really is what we identify is that CER methods and data infrastructure are just strongly interrelated. Without robust, detailed data, methods researchers find it challenging to conduct their work and sometimes impossible to do so. And lastly, collaborations for the development of methods curriculum, which we heard both from methods investigators and training program leaders. Thinking about data infrastructure, the key findings that we have here are that project-specific privacy and data security issues must be prospectively recognized and resolved. Investigators need access to rich, detailed patient data to support research on effectiveness for patient subpopulations. Several effective cross-organizational collaborations that establish key roles and responsibilities for team members were a key element of projects. Several skills were commonly needed for the projects, and work was sometimes more difficult than anticipated, but with experienced project teams, they're able to overcome challenges successfully. And that clinical data collection is greatly facilitated by reducing data collection burden at the site of care. And what we thought about here specifically for implications was thinking about, what should the shape of data infrastructure be going forward, and what areas can HHS be most helpful in developing that infrastructure now? So specifically, what we fell upon is that providing regulatory guidance for holders of sensitive data to facilitate use in CER could be important going forward. That supporting the development of data infrastructure that observes the effectiveness of different treatments in diverse populations could be extremely important to conducting comparative effectiveness research. That supporting the development of data infrastructure that also serves complementary purposes would enhance value to providers. And we heard this actually from a diverse range of investigators across many different types of data infrastructure projects, noting that enhanced value to providers related to patient management, quality improvement, and health information technology meaningful use really could facilitate data collection for comparative effectiveness research. And lastly, to support the ongoing cost of maintaining a data infrastructure going forward. So last we've been turned to dissemination and translation projects. Our findings here are that understanding local context, culture, and resource constraints are important. That projects develop a variety of approaches and tools using diverse technology and media. In particular, projects included examples of social media, texting, computerized decision support, patient decision aids, storytelling, and documentary vignettes in their research. And then lastly, that additional skills required in dissemination and translation projects included implementation science and communications. Now, in terms of implications, what we found is that HHS might consider supporting the development and dissemination of decision tools, also supporting engaging end users' CR findings and planning dissemination efforts. In particular, it's important here because it helps ensure the rapid uptake of research in the point of care decisions. And lastly, to consider promoting healthcare delivery system efforts to translate CR into practice. One example here, for example, is the EHR Receptive program that might offer a mechanism to encourage the adoption. And I'll turn it back to you.
Thanks, Dominic. So Dominic was stuck with the hard part, which was to try to summarize in briefly, less than 20 minutes, findings from over 425 projects investing $1.1 billion. I've got the easy part, which is to think a little bit about what lessons did we learn for evaluating the long-term impact of ARRA or other CER investments. So, of course, now the hard part for you is that we have this eye chart, which is the logic model for evaluating the impact of CER investments. But I'm going to try to make this a little simpler. So at the outside of this evaluation, our team, aided by our technical advisors, including Shelley and Sandy, who are with us here today, and a variety of CER leaders from across HHS, developed a logic model for evaluating the impact of CER investment. And then through the course of our evaluation, we learned a lot about other factors to consider, and we revised this, and now I'm presenting the revised logic model today. So, for example, the environment in which these investments occur is clearly quite important to the ultimate impact. So, for example, environmental factors that we recognized were important to the impact of ARRA CER investments, including the Federal Coordinating Council and its strategic framework guiding CER investment. Of course, the Institute of Medicine CER Priorities Committee and their recommendations were important. The context for the investment, this big investment in comparative effectiveness research, was clearly an important agenda-setting element in 2009. Concurrent efforts by funders like NIH and AHRQ were important, and the existing research infrastructure at the time the investments occurred, the colleges, universities, and private sector firms ready and able to do ARRA CER projects. And of course, as was recognized from the outset of the ARRA CER investment, and then now through the work by PCORI, a variety of other stakeholders are extremely important to the development and use of comparative effectiveness research. Of course, as Dominic has described, the ARRA CER investment created a set of activities in 420 some odd projects. And then the output of these projects were things like new and updated data sets from data infrastructure projects, new and expanded CER training programs or advances in methods for observational studies from the Human and Scientific Capital projects. The immediate outputs from research projects on comparative effectiveness would be interim reports, briefs, perhaps presentations and scientific meetings, and dissemination and translation projects created things like new point-of-care decision resources. Now, a variety of intermediate outcomes would result from these various activities and outputs of projects. Hopefully increased use of new CER databases, more and better CER investigators, increased application of advanced methods, more peer-reviewed publications. We'll come back to the implications for peer-reviewed publications a little later. Of course, ultimately, one would hope that CER findings would be endorsed by professional associations and incorporated into decision tools, quality measures, et cetera. But we recognized over the course of this evaluation that there would be a variety of mediating factors that would influence whether we achieved long-term outcomes like improved healthcare decision-making by providers and patients, reduced unwarranted variation in care, and improved population health. These mediating factors, and I'm going to skip forward here for the sake of time, mediating factors that would influence whether these 420 projects created intermediate and even more important long-term outcomes are going to include the availability of funding for new or follow-on projects. Of course, there, PCORI and other investments in the Patient-Centered Outcomes Research Trust Fund come online. We also recognize through this evaluation, though, that delivery system support for ongoing CER data infrastructure would be important, that expectations on makers to actually use CER findings would be an important mediating factor, that the motivation of delivery organizations to promote the use of CER in point-of-care decisions by clinicians, by patients, would be an important mediating factor, determining whether CER investments made a difference or not. And of course, overcoming the challenge of engaging stakeholders in the development and use of comparative effectiveness research would be important, and how effective various activities were in accomplishing that. That, of course, is a major focus for PCORI. We also noted a variety of other external factors that could affect the milieu in which CER got used. Public opinion, to what extent are professionals educated and now expected in their professional communities to use comparative effectiveness research? Or certainly legislation. In our case, as Dominic has mentioned, the passage of the ACA, the development of the Patient-Centered Outcomes Research Trust Fund, PCORI, CMMI, all of these were important things that occurred during the time of the CER investment that would plausibly have a long-term impact on comparative effectiveness research. So now I'm going to move away from the conceptual framework for understanding the context in which an investment in comparative effectiveness research might have outcomes, And we're going to talk a little bit about, well, what policy questions are appropriate to ask when considering the impact of an investment in CER or PCLR. Well, of course, one should certainly start by looking at what the legislative intent was. Now, the Recovery Act was a very big piece of legislation, and so there aren't pages and pages of report language on CER. The report says that the CER funding should be used to conduct and support research to evaluate and compare the clinical risk and benefits of 2 or more medical treatments and services for medical conditions. So then the expected near-term results from this appropriation would obviously be CER research, or since the investments were supposed to support research on CER, training programs, methods projects, infrastructure projects, all the kinds of investments that we saw through the Recovery Act would be the near-term expected result from the ARRA investment. Now, what of course would have been the long-term policymaker intent? Well, if you consider all the things that were being written about at the time, obviously the ultimate hope was that better investments in CER would result in improved efficiency and quality of care, and ultimately overall better population health. Great question. As you might imagine from our logic model, probably would take decades to discover whether that is what happened from the ARRA investment. That would be an interesting question for historians and for their dissertations, but probably not for policy researchers. So let's reframe this into policy research questions. Well, certainly, what is the impact of the CER investment on improved healthcare decision-making by providers and patients? Is the kind of question that would be very interesting. More narrowly targeted but important question, has there been increased application of the advanced CER methods that were developed? Have the CER findings been incorporated into quality measures or decision support? All of these, as you can understand from our conceptual framework, have to be understood in the context of environmental factors that facilitated or challenged achieving those outcomes, and mediating factors that would promote or create barriers to the success of projects. And those, of course, are also very interesting policy research questions. What are the environmental and mediating factors that promoted or detracted from the success of these investments? Of course, there are also research questions that would be relevant to the ongoing work of funders of comparative effectiveness research, certainly federal agencies and possibly PCORI. Are CER projects meeting their stated project and program goals? What gaps remain in strategic priorities? What opportunities remain for further investments? And then a more particular kind of question that research agency funders might be interested in: what are the project or research team features that facilitate success? What are the factors involved in sustaining effective collaboration in multi-institutional clinical trials? How do you engage research mentors more effectively in these complex new kinds of research projects? How do you facilitate these multi-institutional, multi-perspective data infrastructure projects? And how do you overcome the kinds of barriers to stakeholder engagement that we learned about through our interim evaluation? Now, we also learned a lot of lessons regarding what are the different methods for evaluating the impact of a diverse set of projects like these. We learned a lot about investigator and stakeholder surveys and how those could be used to evaluate the impact of CER investments. We explored in some detail a technique called social network analysis as a method for assessing project team features that might facilitate project success. But I'm going to focus on something that's a little more straightforward and easy to talk about, something familiar to, I think, the policy and research communities. What about publications as an outcome metric for comparative effectiveness research investments? Well, the advantage is they're widely understood and relatively transparent. It's easy to count them, And in fact, many aspects of publication search can even be automated nowadays with electronic bibliographic indexing systems. So we did, as part of our interim evaluation, a snapshot of what publications had been produced as of November of 2012 through the ARRA CER investments, and we identified a variety of interesting challenges. First, the ease of detecting publications varies substantially based on agency funding. Anyone who has been funded by the NIH will understand that investigators who have NIH grants are expected and required to submit information on their publications from their work to the NIH and to journals. So you will be able to detect all of the publications that emerge from a project from the NIH. Such requirements are not there for projects done by CMS, for projects done by the Office of the Secretary. So because ARRA CER was invested through a variety of different agencies and authorities, all of those projects were not submitted under the same set of rules that apply to NIH grants. Even for NIH grants, we discovered that grant numbers are not standardized in the way they're submitted. So it's not necessarily easy to make sure that you're always finding the right grant and you're tracking them back. You can create algorithms to do that, and we did that, but it's not necessarily straightforward. A more interesting and challenging problem is what about when multiple grants are cited? A lot of these investigators were large teams, as you've heard. Some of them are involved in multiple projects at multiple institutions. So how do you know what was the relative contribution of a particular CER project? Of course, you might need to search the gray literature because not all of the work would end up in the peer-reviewed publications. And we also considered in some detail whether one could use investigator surveys to enumerate publications, but that gets into its own rather obvious challenges. And then there are conceptual challenges with what you do once you have a list of all the publications. Do you compare the absolute number of publications from different projects? Publications per dollar invested? Do you look at the impact factor? However, there are varying conventions about publications across disciplines. Some of the disciplines, for example, academic internal medicine has been accused of creating the least publishable unit, which is as many publications as possible from one grant. Other disciplines may combine the work of several different projects into one substantive monograph. So the sort of rate and timing of publications can really vary even by disciplinary convention. Of course, different types of projects and different kinds of investigators have varying motivation or opportunity to publish. And we identified, at least at the time of ARRA CER, for example, that methods projects don't necessarily publish at the same rate as original research projects. Clearly, systematic reviews are going to be published a lot sooner than a randomized controlled trial. So there are a lot of timing issues. And then how do you enumerate outcomes like statistical methodology code, which doesn't end up in the peer-reviewed literature, or the relative usability of a CER database, or the dissemination of an important electronic health record decision support tool that doesn't generate any peer-reviewed publications, but might be widely disseminated throughout delivery systems around the country and have a tremendous impact. So a lot of potential challenges to how you use publications as a simple outcome metric for evaluating the impact of comparative effectiveness research. Now, so Dominic and I have provided our overview, and now we look forward to hearing the commentary and reactions from our discussants. And first, I hope that Shelley Greenfield is still with us from University of California. Shelley.
Yes, I'm here. Can you hear me?
Yep, hear you great.
Okay. First of all, I'd like to thank you for inviting me to comment, and to also say that I am much appreciative of the work of Jean and Dominic, particularly in the rigor of this evaluation of a rather messy subject and changing right under their feet. as well as the lucidity of the way they present the information. My overall comment, most overall summary comment, following the presentation, is that I think the ARRA funds, their most important contribution, apart from the ultimate findings, as Gene has pointed out, will be that the ARRA funds kick-started the CER paradigm shift. It basically allowed the teams to operationalize the rather abstract and vague notions that were put forward in the IOM and other committee reports because they needed to be specified. And these projects had an important and salient impact on research as they tried to overcome the challenges that are presented by comparative effectiveness research. And I think as a result, it basically lent confidence not only to PCORI and PCORI investigators, but to the whole research community in terms of thinking about the ability to actually have CER be a major factor in future research and do what it's intended to do. Now, what are those challenges? They've been enumerated before. I'll just briefly list them because they're very difficult to put into practice. Getting the right comparator, a difficult problem. Dealing with subgroups so that medicine and decision-making can be personalized. Dealing with and building databases and infrastructure, so particularly that harms can be codified and addressed. Dealing with the collaboration of different kinds of organizations and different kinds of settings, particularly, as Gene and Dominic emphasized, non-research organizations. The multidisciplinary nature of this kind of research. Training, the training of new researchers in this, if you will, expanded field. How to engage stakeholders, which sounds very good, but is very difficult to operationalize and make meaningful. And then finally, new methods, which, as Gene and Dominic have pointed out, are needed to accomplish the goals of comparative effectiveness research. So I think that these projects and all their interactions have really pushed the field forward, even short of having in hand the ultimate findings. I'll give you one, if you will, personal example of this as I end, which is to say that there's an NIH ongoing study. I'm not going to identify it. And I was asked to comment not on the study itself, but on the degree to which it was aligned with or congruent with comparative effectiveness research. And my initial conclusions were that it was rather far away from the goals and congruence with the elements of comparative effectiveness research. And as a result of the comments of me and people like me, the people at the NIH went back to the study. Actually, and it had already started and have amended major parts of it right in the midst of the study to try to conform better to comparative effectiveness research. So I concluded from that anecdote that culture is difficult to change, but that it is definitely changing, and it's changing in the direction of the goals of comparative effectiveness research. So I'll just end my comments by saying that I think the research community is now, in part because of the ARRA funds, much more attuned to understanding the major issues and challenges in comparative effectiveness research, and that these funds have facilitated the ongoing paradigm shift. I'll end there. If there are any questions for me, I'll be glad to answer them.
Button, right? Well, first of all, I also would like to thank Gene and Dominic for inviting me, both as with Shelley, to be part of the process, the advisory process, and also for the opportunity to participate today. I was also particularly impressed with the rigor of the whole process and the whole study, and also the openness that Gene and Dominic and all the people at Mathematica had in terms of seeking a broad range of often conflicting inputs, but it really permeated the whole process, and they really were committed to excellence, and I think it shows in what they found. And I think today we're really at an inflection point about thinking where to go next with this. And what Gene and Dominic asked me to do was to talk for a few minutes about some thoughts about longer-term evaluation, intermediate long-term evaluation. And I think this is really, really important for a couple of reasons. One is, as Shelley noted and suggested, that CER and patient-centered outcomes research is really fundamental to everything we're doing in healthcare and healthcare reform. It's not always explicit, but it's implicit. Unless we're going to be in a zero-sum game, unless we really believe that we're going to find great efficiencies in care, if we're going to expand access and improve care at the same time, we're going to have to learn how to do things better. And those of us who work in the healthcare system know that it isn't a bunch of people trying to do bad jobs. It's we don't have the information we need to make the right decisions. And as Shelley noted, there's been a fundamental shift because of the ARRA and now PCORI in changing the landscape. The genie's out of the bottle, and I've been extremely impressed. My own research is at the interface between research and application with practice and policy makers. And really, you can't go anywhere without people thinking in terms of how does this compare, what is this, a different level of expectations, and also the patient-centered focus. And what makes the evaluation particularly important is that this is a new area, and we're learning how to do it. In medicine, we often say it's see one, do one, teach one, and here it's do one. We're creating this as we're going along. I was thinking about it. It's like Brian's building a house. It's like building a house, designing a house and building it at the exact same time. And I think that there is the need, though, at this point, as Gene said, this is midstream. We're now well into the process, and we need to ask fundamental questions like, have we identified the correct priorities? Do we have the right scientific strategy for scientific capital and capacity? What about human capital and capacity? All these things we took our best shot at under very short time constraints a few years ago, but now we have some experience, and it's important for us to do a rigorous job of evaluating what we're doing. So I have just 7 brief comments. First is, I think the logic model that the people at Mathematica developed is a very good conceptual model for thinking about this process. I think it's a great start. I don't think it's the end-all, be-all. I'm not going to go into any specific suggestions now, but I think the reason for having this session and a subsequent one that's going to be coming up at Academy Health is to start the process and open this up and say, is this right? Where do we need to think about other things? But I think this will be the fundamental core of how this is looked at going forward. Second, I think we need to ask in our evaluation, one of the key issues that comparative effectiveness research and patient-centered outcomes research has done is introduced in a really meaningful way the recognition of the importance of multiple stakeholders. Now, we all have understood this for a long time, but I think if we're honest with ourselves, we'd say that it was really not part of the research endeavor and even the clinical enterprise until very recently. So I think we need to go back and talk to the stakeholders and find out what do the stakeholders need, what do they want, and that should really guide whatever the longer-term evaluation process is. And that leads to the third point is I think it's really important to think about this in terms of structure, process, and outcome, just like we do in quality. We're going to be able to measure some things in the short run. The best way is going to be able to do it, unless, as Gene or Dominic said, we're going to be waiting generations to get answers, is to measure what's actually being done and what the short-term impact is on the process of care and on the process of policy. But I'm going to emphasize the real need to look at outcomes in ways that can be done that may merge the two. And I think the focus has to be on questions that matter. So I think the evaluation process should focus on where does this make a difference? What is it? Yeah, this is new, but is it really new? is the training real? Are we really training people in a fundamentally different way with different skill sets, or are we sort of taking them into the programs we already have and crossing a T and dotting an I and moving a chair on the deck of the ship and saying that we have a new boat? I think there's a lot of old wine in new bottles, and we have to make sure that we're really asking questions. So, for example, what can we do in the short run? We can say, is the content of the research, are we asking different questions? Is it being conducted in a different way? We can go back and compare the way studies are being done now to how they were done 5 years ago, looking at clinical questions. What's the impact on practice or even on short-term patient outcomes? Are patients adhering better? Are they making different choices? And ultimately on population health. And that's going to be a longer-term perspective, but we can look at trends and we can look at intermediate measures. As I said, this needs to be outcomes-based, and we can look at things like, has this information reduced uncertainty by doctors and patients, particularly patients, in how decisions are being made? And are we seeing reductions in harm? Are we seeing greater access to effective services and providers? Now, with this comes the presupposition, if you build it, they will come. You know, that we really understand how to use this. And I think one of the important things, as I've lived through this for the last 5 or 6 years, is that we really need to see how this information is being used. It's like a lot of things in life, you know, sometimes it's being used well, sometimes you can never go wrong underestimating somebody's ability to screw things up. Usually somebody's saying that about me. But I really do think that we have to look at how the information is being used, where it's being used appropriately, and what we can do to make sure it is having the impact that's intended. Finally, I think that the evaluation process should focus on what's innovative about what we're doing. Innovative ways, as I said, of training people, innovative ways, new metrics about how we communicate the information, new data sets, and what's their accessibility to investigators, and what difference is it making. There are a lot of new things out there, but we want to make sure that those new things are actually going to make a difference in how things are being done. So that's where the process comes in. We can look at these new structures and figure out which ones are really changing, which ones it's just another way of packaging the same information, and then on the basis of that, we can get some insight into where we might look for the outcomes. So I think I'll end there with one last comment. I don't think you guys should feel too concerned about the difficulties in looking at publications, because if you ask me what the least meaningful measure of effectiveness would be, and this is from an academic whose CV is longer than it should be, publications I think are probably, they're useful to some degree, but not very useful, as for all the reasons you said. I've always been a lumper, not a splitter. I'll go through and have 1 or 2 publications come out of the study, and the funder sometimes will say, but so-and-so had 30 publications coming out of the study. So I think it's worth monitoring, but I think that in the past, NIH, ARC, HHS, you know, CDC, I've been funded by all of them. They put far too much emphasis on the numbers of publications and would be better off looking at the outcomes and the impact on what we do.
Am I on? Yes. I'm red-green colorblind, and I can't tell. So it is a pleasure to be here, and to follow Shelley and, well, all of you, obviously Gene and Dominic and Shelley and Sandy. I'm from Picori, and so all of what you're doing and have done, and all of the funding itself, the evaluation and these remarks, you know, I'm filtering through the Picori lens, because we're on this train to do a lot of things similar to what was intended with, and then to evaluate the Picori processes and outcomes and activities and projects as you have been doing. So my first thought is, I want to invite you to Picori, the two of you,
I really do, actually. I think that what I'm listening to and what I'm learning is extremely germane to what we have to do. And we're in the middle of evaluating and setting up the metrics and logic models, and also right this minute. So I note that we are really, like standing on the shoulders of others, as the query is, and the evaluation process that we are going and will be going through is somewhat standing on your shoulders here. That Mathematica has been doing. All of the work that the query is doing, and the focus of it is really builds very, very nicely on what was expected to happen with ARRA and what evidently has been happening with ARRA. Although there's been specific deeper dives or different kind of dives that I'm going to mention that I think we'll learn a lot and probably spill over some learnings to your folks as well and others. To give you a sense of how important evaluation is from our standpoint, GAO is already in our door evaluating the query, and our legislation sunsets on 2019. And so we'll be essentially evaluated by 2017, and Congress, in the legislation itself, expects that we will have changed practice patterns. So you don't have to do much math to figure out that ARRA is, 4 or 5 years into this process. By 2017, we'll be about the same. And so we are trying to figure out how to demonstrate the degree to which we changed practice or made a difference. It's also sobering to as I listen to you, how long it takes to show results. And we're going through that process, and some of the things that I'm thinking about that you may want to consider if you have the opportunity. I don't know exactly where you are in the evaluation process. You continue, or are you going home? You're done, okay. Then I'll tell you what you should have done. But what we're trying to do, and I think it still could be done with respect to ARRA, is better understanding the patient-centeredness part of the process. In other words, to what extent has patient-centeredness been implemented, and what differences has it made? I'm fascinated by the degree to which the ARRA imperative was included stakeholder involvement. That is a central focus of what the query is doing. We do it from the priority setting process all the way through the requirements for applicants to include stakeholders, especially patients, by the way. I say stakeholders. I mean, actually, we talk about as patients, patient advocates, and stakeholders, if patients weren't stakeholders, but it's a particular focus on patients and patient advocates. And so they're part of the process, literally, in developing our priorities. We require our applicants to have stakeholders, and especially patients and patient advocates, and other organizations, part of the process, very similar to what many of the projects you've looked at. I don't know the degree to which they were required to do this. And then our review panels, and their review panels, I'm sure are different, include multi-stakeholder and patients in the review process itself. And finally, we require that the patients and the stakeholders have to be part of the research. So we're doing a deeper dive that I expect. Although I'm sure you have some projects that are that deep. So when I think about evaluation, one element of evaluation that can be done is to look at the difference that process makes in terms of the way in which research is being formulated, the questions that are being asked, the design of studies, and and the nature of research itself. And so it's a process that's actually sort of an intermediate outcome. Whether it makes a difference in the final analysis is one thing, but at least we'll be able to, and that's what we're going to be trying to do, try to determine whether in fact the research itself is differently focused. So is our asthma research, for instance, different than the asthma research that's been done in the past? There's so much overlap that it's just unbelievable. The methodological issue, the investment in methods, we have our own methodology committee and require our applicants to follow methodological standards, which is essentially a floor. And we are required to ensure that they adhere to those standards, which is, so it's sort of building on what ARRA has done, and it's really been very interesting to see more and have a better sense of what the specifics. Now, when is your report coming out? Because we really want to read it.
I was going to mention this later, but we will be submitting next week a series of papers to the Journal of Comparative Effectiveness Research.
Yeah, you mentioned that.
So watch for those in the fall.
So a lot of the detail will be there.
But the detail will be there. But I should also mention that at Academy Health, there'll be a number of presentations, including something that you may find very interesting around the methods issue, which is we looked at how the ARRA CER methods projects engaged extant CER methods priorities that were around at the time of ARRA, including the initial methodology report. So that's material that we got that we can share right away.
So one particularly interesting thing with evaluation that could be considered is looking at sort of the step therapy, or what do you want to call it, from essentially little to no engagement to intermediate engagement to deep engagement, to what they're requiring, and to see the degree to which engagement is important and how it differs at these different levels and how it changes the research focus and the research itself, as well as ultimately the outcome. Because it could very well be that Corey is overdoing it, and that the kind of engagement that has been done within the ARRA projects is insufficient, or it could be insufficient. So just a thought there. One other thought is that, although you didn't specifically mention it, ARRA funded a wave of pragmatic trials, essentially identical to what we're doing right now. We're funding 2 waves a year, 3 actually this fiscal year, of 10 trials a piece, approximately 8 or 9 trials a piece at $10 million of direct costs each. And that's almost exactly what ARC did. And ARC's pragmatic trials are just completing right now. So I literally think of what ARC did is our phase 1. And then we will learn from that, because the pragmatic trial issue is really what was in the mind of Zelensky back in 2003, when she thought about comparative effectiveness research and funding trials. She was thinking about funding these kinds of trials. So I'll stop. One other thing is the infrastructure. The infrastructure that ARC has done, I'm sure there's a paper coming out on infrastructure. We'll be looking closely at that. As some of you may know, the Corey has focused our infrastructure investment, $100 million into PicoNet, which is essentially 20 individual awards, but they all have to play nice together. The requirement is that it's one network, in essence. And that will, I'm sure, build on what you've learned with the infrastructure and so forth. So there's a tremendous amount of learning and overlapping that I think we should continue to build on and learn from and ask for your consult as we go through. Learning networks of the other things that I had notes on, that we're also employing learning networks are putting them together and funding them together to see how they work and evaluating that. Is there a paper coming out on learning networks by any chance? That could be the 11th paper.
Yeah.
if you need another pager. So thank you very much for inviting me. I find it fascinating, and I can't wait to share this with my colleagues.
So thank you all very much. And now we look forward to answering questions from the audience. If you're posing a question in person or online, please state your name and affiliation. We'd like everyone to limit themselves to one question so that we have plenty of time. All right. So first, a question from the audience. No one raised. Oh, there we go.
Thanks very much. Oh, wow, that's loud. I'm Diana Bust. I'm from Group Health Research Institute and also Academy Health. I have a question about the intermediate outcome in the model that you've put forward. Are you proposing that these intermediate outcomes have already been demonstrated as a result of your evaluation, or is this a proposal for what those intermediate outcomes might be for further evaluation?
Yeah, in the conceptual framework and logic model, the intermediate outcomes were large. They were conceptually listed as things that would be the kind of expected intermediate outcomes from these types of investments. In most cases, they're not things that we would have observed. Largely, the things that we were able to observe in this midstream evaluation would be those sort of things that we call immediate outputs and project metrics. So, for example, we sort of heard that folks were starting to make use of the CER databases, but because this was a midstream evaluation and many of the databases were still getting linked up while we were evaluating them, in many cases they couldn't be used yet. So even there, that was not something that we could realistically evaluate in midstream, but that would be something that would be an intermediate outcome to look at in the future.
So as part of the Journal of Comparative Effectiveness Research articles that you're putting forward, are you going to make proposals as to how, just as an example, how you might measure whether or not CER is relevant to decision makers as an evaluation component, or make some sort of proposals as to best practices for how some of these metrics could be assessed?
Yes, we'll provide some of those insights and in the course of the different reports. Yeah.
One of the things I think that's going to be important in doing this going forward is the recognition that we need a better typology for how we classify the outputs of clinical effectiveness research or comparative effectiveness research. As you know, it's a matrix, and you can look at it by disease, different diseases, or different types of questions. You can look at it by method. You can look at it by population. You can look at it by system. You can look at it by the stakeholders, how it affects various stakeholders and decision makers. And then also it's important to look at it by projects, individual projects, by programs, and by the whole portfolio of programs in the enterprise. So I think we really need to think about a matrix type of approach where, depending on what the area of interest is, you're going to have a different lens by which to look at the evaluation process in the intermediate term and in the long term.
The other observation that ties both of your points together, one of the things that we explore in more detail is the way in which a more thorough ongoing inventory of all the projects going on, and sort of looking at, what methods are those projects using, what kinds of stakeholder engagement were involved, that having a better understanding of the databases that were being used on those ongoing projects could be very helpful to future evaluations and to the CER and PCOR community. So we do explore that in more detail as well.
I'm Jerry Carabotto. Hi. Thank you. I'm Jerry Fairbrother. I'm a senior scholar at Academy Health, and I thank the presenters also for a wonderful program. And I, too, had a question about stakeholder engagement, which is such a new thing with this sort of research. And I'm wondering where you think we stand with respect to kind of getting a handle on some of the issues. For example, Dominic said, as many have said, observed how resource intensive it is to involve stakeholders. I wonder if we want this to be a part of the way the research business, part of doing research business from here on out. I wonder if we need to, and if there are any efforts to get a handle on what level of resources and what needs to happen to engage stakeholders at the varying levels, all the way up to the deep levels that PCORI wants to do. And I guess along with that, payers are also, I mean, we've talked a lot about patients as stakeholders and the effects of involving patients, but I'm wondering what you might have to say about the effects of involving, how payers could be involved and the effects of involving payers. They're the ones, after all, who will need to make the decisions around coverage and payment that will have a lot of influence on whether the results are implemented or not.
You want me to address something? Am I on?
Sure. I mean, you sound like
I did press it, but I can't tell you. Am I? You all can hear me? Good. Well, first of all, we have a very active, focused effort to evaluate the stakeholder engagement process and outcome of that process to develop best practices, learnings, and publicize that. PCORI also has a really, really good component on its website called the stakeholder rubric, I think it's called, and it's engagement rubric. And it is as good as we can do at this stage. I think it's very good, and people think of it as very useful. So we'll be doing the engagement research itself, so researching engagement, as it were. But what else do I want to say about that? Something else. Oh, the payers, yeah. The payers have maybe predictably held back a little bit about being active stakeholders, and we're reaching out to them ever more in terms of both addressing topics that they've submitted to us, but we've had to actually hold the topics from them. But just tomorrow, I'm having major players come in at their request on a major issue that they're interested in, major technology, science, clinical, and cost issue that they are interested in PCORI being the funding agency for. So we will see how that works. But we do have, especially with the pragmatic trials, we have payers engaged and so forth. But I think that it's not going to simply happen. It has to be stimulated and pulled and developed from external to payers. The inclination is to hold back, I think.
Two thoughts about it. As somebody who was involved in a couple of AR grants and have several PCORI grants, or involved in several PCORI grants, I think this is one place I might disagree a little bit from the conclusions. Not that you didn't find that, but I don't think it's that hard to engage stakeholders. We haven't found it. It takes effort. You have to think about it because we're not used to doing it. I do it in all my research now, even that's not required, because I found that it leads to better questions, better methods, and better adoption at the end of what you find by the target that you're trying to reach. So I don't think it takes that. It takes time, a little bit of time. It takes a little bit of resources, but it's not that difficult. And I'd say it's much easier to work with patients as stakeholders and patient groups as stakeholders than it is to work with other investigators. and then the egos are a lot smaller, and everybody's focuses. It also focuses everybody to really focus on what we're doing the research for. And so I don't think that that's a barrier. I think it's been one of the huge successes, actually, of ARRA. I think at the beginning it may have been more of a problem because people weren't used to doing it. And also, I think a good chunk of the research that was funded by ARRA was funded by people who may not be comparative effectiveness researchers, but they had a research question and they were on the run since time frames are short, trying to figure out how to adapt it so they could get access to this pile of money. And the other thing about payers, I would just say, is I personally think that that's a really important question, but that we need to be very careful because payers have different incentives, usually, than do patients and the people who care for them. And it's another topic for another day, but I think as we think about how these things are implemented, we ought to think about arm's length relationship that make sure that the payers focus on the science and not on the convenient science. So that's just an editorial comment.
Well, I know Shelley Greenfield has been listening patiently and is not in a position to be able to sort of wave his hand. And, of course, Shelley and his colleague Sheree Kaplan have done a lot of work on the patient perspective in outcomes research over the years. So, Shelley, I don't know if you're on, but do you have any comments regarding what you observed ARRA, CER, and patient engagement?
Yeah, I'll just make just one comment, because I also, and Sherry also, we're involved as co-investigators in several of the ARRA projects, and another one is taking place in our unit. I'll just make one comment about that in appreciation of Brian's note that the field of stakeholder participation, notwithstanding the fact that Sandy said it was easy, I would say it's not so easy to do this, and a lot depends on the level of sophistication or the history of the project. We're involved with one project on prostate cancer in which the stakeholders are very sophisticated because of the last 10 years of research and understanding of the patient's role in choosing prostate cancer treatment. In other areas, we're working with a poor population of patients with diabetes. They have very little clue about how to engage research, and they're going to need a lot of, actually, say, interaction and training. So I would say that this field is just beginning to flower, and I think we're going to see a lot of very interesting things happen over the next 5 or 10 years.
And Shelley, I don't disagree. I would just say that I was thinking about the organized stakeholders. I think when we start getting into community and community participatory research, it's a different game. It's much more challenging. I would agree.
I was going to move on, but the current largest funder of patient-centered outcomes research wants to make another observation, so I think we'll defer.
But just one quick comment here. Am I on? That it is, you need a long-term engagement, relationship here. This is not a one-off deal. And that there's a cadre of smart health service researchers around this country that know how to do this and are very eloquent in talking about how it actually works. But it requires a long-term trusting relationship. But once you have that, I think it works.
So this is one of the frustrating aspects of trying to present everything we learned from the Recovery Act evaluation in really 30 minutes. We had a whole focus on the stakeholders. We looked at a variety of different stakeholders because, remember, this was funded pre-CORI, and our stakeholders included a variety of other kinds of stakeholders that you might think of: delivery system leaders, innovators, payers. We also did a deep dive. We have 2 papers that will be coming out where we look at what was learned about public views about comparative effectiveness research. What issues were the investigators wrestling with? I can just briefly note that none of the RFPs required stakeholder engagement. The first official signal that would be important was the Federal Coordinating Council's report, which spoke to stakeholder engagement and included patient perspectives. Of course, the I01 Priorities report mentioned that as well. And I would say that we heard in our discussions with various investigators that this sounded like a good idea, but was new to them. So, so there was a lot of trial and error in that regard. Now, I know that I'm going to quickly switch because I think we have a question from the webinar group.
Yes, Larry Kessler says, measuring outcomes is the most important thing to do. Medical decision-making is so complex, and teasing out the effect of one CER study will be very hard. Might you consider the formal incorporation of CER results in professional guidelines as an outcome?
Yes, absolutely. Great question, and we allude to that in our framework by pointing out, say, endorsement of findings by professional associations, and so that we were sort of signaling that guidelines and similar kinds of activities. I'll note that the current activities that are called choosing wisely, that many professional societies are doing, you will not find the term guideline attached to those. There are some professional societies that are more enthusiastic about guidelines than others, and that's why we sort of signal that there are a variety of professional endorsements of evidence. Some of those, of course, would be formal guidelines. So thank you. I think there was, yes.
Hi, Jean. Karen Lohman-Siegel, currently with the Veterans Administration, but was with AHRQ at the time the comparative effectiveness monies came in. And I just wanted to follow up on your last comment about the specification for stakeholder engagement. And one of the things that we devoted some of our resources to was the evidence synthesis program, and we had some of our evidence-based practice centers expand their role in some of the activities they were working on, and they did do stakeholder engagement in that evidence synthesis program. So I think that raises one of the challenges you might have had in tracking all the activities that the funds were distributed to in the activities that you were doing in this evaluation. But certainly as part of that evidence synthesis program that the evidence-based practice centers were working on, stakeholder engagement at various points during those evidence synthesis activities, stakeholder engagement was a big part of that. And I can't remember if the community forum that developed, but
absolutely.
Yeah, that's another one.
Part of the investment as well. And I was referring more to, if you looked at the general RFPs that went out to NIH-funded researchers that they were responding to, and you looked at those funding criteria, those sort of typical kinds of things that the academic would look at. It didn't say, as it does say for PCORI, you know, one of your criteria will be the following. But you're exactly right, and thank you so much for clarifying that. There were a number of projects that were very specifically exploring this idea, and that was directly in keeping with guidance from the Federal Coordinating Council for Comparative Effectiveness Research. Very good. Is there another on webinar question?
We have another question from Harriet Arno. Was there any analysis or evaluation of the interprofessional team representation in the funded CER research? It seems like MDs dominated in the PI-funded projects, but what about nursing, other allied health professional team members as PIs?
Dominic, I know we had data on that. I think I'll defer to Dominic.
Yeah, great. Thanks, Jim.
Dominic is saying, yeah.
So in terms of interprofessional teams, we did get a chance to examine a little bit in terms of who were leading the teams. Primarily there were PhD researchers and some MD clinician researchers as well, some MD PhDs. It eludes me whether or not there were a lot of nurse researchers leading teams, but that doesn't mean that there weren't nurse researchers on teams as well. So one of the things we did try to do is get some sense for subsets of projects, the interdisciplinary nature of the teams. They were pretty diverse by and large. There were lots of different teams. And what we found when we looked pretty deep into the research projects, into the training projects, training programs, and the methods project, was that, and the data infrastructure project for that matter, was that it really took a lot of different types of expertise to really lead to success of those projects. It wasn't only a PhD or PhD MD researcher or a clinician researcher. It was also the programming staff that you had. It was also the clinical staff that you had specific expertise in what you were studying. It was also the methods researchers who were on your team. And it was also those individuals who could work with the data on a regular basis, understood the ins and outs of the data. And as I mentioned, a large proportion of the project also included non-research collaborators. And those collaborators were also extremely important to many of the projects because they had a lot of the details about the populations you were working with, about the data you were working with, and the ins and outs of those data, and just about working with their own colleagues for that matter and collaborating. So in a roundabout way, I'm trying to answer that question, but that's generally what we found. Yeah.
And I'll also mention one of the things that we learned from our investigation of the training programs. In contrast to many of the more traditional health services research training programs that these developed, these training programs tended to involve more departments and more disciplines. And the projects generally involved more disciplines. The trainees often included folks from backgrounds other than, say, physicians in medicine. So we were definitely seeing the signs of a much more diverse research workforce in preparation and a broader range of disciplines and expertise needed to train them.
But I think the question is, in addition, I like the question because it raises something that was related to something I'd written down but didn't get to because of time, and that is, I think it would be useful to look at the composition of teams and also the meaningful involvement of multi-organizational collaborators and see how that predicts or doesn't. Danny Kahneman, who knows an awful lot about behavior and cognitive decision-making, it says that some of his best work has been done when he works with somebody who is diametrically opposed to him, and it forces them to sort of create a design and a study that would convince either one of them, depending on who's right. And there are, and some of the more successful large randomized trials that have been done over the years have taken that approach of getting people who feel differently about the value of something like it. So I think that would be an interesting metric to look at as PCORI goes forward, looking at its portfolio.
And Sandy, I'll have to buy you that drink later because that allows me to bring up the fact that one of the papers will be on the potential role of social network analysis to evaluate the composition of teams, the disciplines, the perspectives, and how those features might relate to the ultimate impact of the research. So that was an issue that sort of came up, methodologically challenging to do, but a technique nonetheless that could explore that more formally. And the impact is, sounds like you are. Can you hear me now?
Okay. The impact is more than just the nature of what the research findings are. It is what they're accepted. And at least from the current standpoint, there's essentially, I think of it as a belief model, that if the stakeholders, the relevant stakeholders are involved to begin with and throughout, then the research findings will actually be more likely to be implemented, which we all know is a problem.
I would just say it's really good to connect to Brian when you're at a meeting because you can take all the red candies and he doesn't know it.
Let's see. We might have time for one more question. Looks like there's another question in the audience, someone who's been waiting patiently.
Thank you. Jess Wilhelm from Social and Scientific Systems. My question ties into two of the previous questions on measuring the impact of CER research after the research projects have been completed. And I want to know what other strategies you think are appropriate for evaluating how CER research outputs are crossing the implementation gap and getting into clinical and system practice. Thanks.
Well, we have a team at Mathematica actually for a project for ARC, which has been doing a lot of thinking about what are the most efficient ways to do policy research on that relate to point-of-care decisions. And we've in fact been using the choosing wisely examples as examples of how to try to do that. I think everyone is familiar with the recognition that there are variations in decisions at the point of care. Some of those are appropriate to individual patient perspectives and preferences. Some of those are more problematic in their origin. But we currently lack sort of a broad, reliable set of resources to observe those variations at the point of care. So watch for that, but that is ongoing work we've been doing on how could you measure those variations in decisions at the point of care in a way that takes into account the relevant context, including the patient perspective, which Corey has emphasized is so important. Great question. Well, I think we are at the hour, so we're going to wrap up our formal forum. We hope you've enjoyed today's discussion. Please be sure to let us know how you think by completing the comment card or the electronic survey, and watch for that special issue of Journal of Comparative Effectiveness Research in the fall. And also be alert that in June of 27th, we'll be presenting some more work from that AHRQ project I mentioned, this one on measuring comprehensiveness of primary care, past, present, and future. Thank you all very much. Thank you very much to all of our panelists.